This is a presentation to highlight the results of an OA audit within ULHT therapy. So a little bit of background to start with. The NICE guidelines for OA, the carer management, they were first produced in 2008 and updated in 2014. From these, quality standards were then published in 2015. Now, before we go on, a little bit of information about the difference between clinical guidelines and quality standards. Now, clinical guidelines are usually produced first and these give recommendations for clinical practice. However, quality standards then use these guidelines to set out the priorities for quality improvements within this area. The audit was undertaken within physiotherapy in 2017. Each site collected 10 records of patients who had been diagnosed with lower limb osteoarthritis, either hip or knee. The clinical audit was then done by the 5 relevant quality standards. Within occupational therapy, it was deemed they were insufficient patients for a comprehensive audit to be undertaken. The quality standards highlighted 5 areas which were relevant to therapy. Statement 1 is about adults over the age of 45. They are only diagnosed with osteoarthritis clinically without investigations if they have activity-related joint pain and any morning joint stiffness lasts no longer than 30 minutes. Statement 2 is that adults newly diagnosed with osteoarthritis have an assessment that includes pain, impact of daily activities and quality of life. Statement 3 is that adults with osteoarthritis participate in developing a self-management plan that directs them to any support they may need. And statement 4 is that adults with osteoarthritis are advised to participate in muscle strengthening and aerobic exercise. Statement 7 is also relevant, and this states that adults with osteoarthritis are supported with non-surgical core treatment for at least 3 months before any referral for consideration of joint surgery. So now if we look at the results, starting off with statement 1 regarding the diagnosis without an X-ray, of the 40 patients, 60% had already had a referral from mainly the GPs prior to their referral to physiotherapy. Of the remainder, none of the others had an X-ray either arranged or suggested by the physiotherapist. Statement 2 regarding the assessment was very positive, with 95% having elements within the assessment that incorporated pain, quality of life and the impact of daily activities. Statement 3, looking at self-management and information, shows that 7 of the 40 had recorded that written information was given to the patient. All patients had a management plan within the record. For statement 4, which is regarding muscle strengthening and aerobic exercise, the results were very positive, especially regarding muscle strengthening. 100% of patients were shown muscle strengthening exercise. However, for aerobic exercise, only 14 of the 40, which is 35%, had specific information within the clinical record that aerobic exercise had been given or advised. Statement 7 regarding the referral for consideration of a joint replacement was not recommended or a referral suggested in any of the cases. So, what are the learning points to gain from this audit? Let's start with exercise. Muscle strengthening exercise is recommended within the quality standards and the clinical guidelines. It does not specify a type of exercise, one being better than another, but the importance of making this individual to the patient. This was definitely seen within the audit, as many different types of strengthening exercise were given by differing therapists to differing patients. Aerobic exercise, on the other hand, wasn't routinely written within the record. Now, this could be down to several reasons. One being that aerobic exercise isn't being advised, or when it is being done, such as walking or usual general exercise, it's not being recorded. I think it's important that we consider normal general exercise, including walking, as a therapy or a therapeutic activity in its own right and a form of aerobic exercise. This should be advised to the patient, not just for OA purposes but for general health as well, and therefore should also become part of the clinical record. Written material wasn't routinely given to the patient. However, in today's information age, there are more than one way of giving information. It isn't always appropriate or required that written information in the form of a leaflet or written instructions is to be given. This could be in the form of information regarding the websites. Two of the main websites which can be utilised is the Arthritis UK website and the NHS Choices. However, if this information or resource is given to the patients, again, if it's written in the record, then it can be clearly seen and evidenced. There are further learning points. Physiotherapists did not recommend an X-ray for patients that they had seen with lower limb osteoarthritis. This, however, had been undertaken in a large proportion of patients by the GP in primary care, and this is beyond the control of the physiotherapists. Continuing to ensure patients are not recommended for total knee and hip replacements within 3 months should continue. There are limitations to this audit. The NICE guidelines and quality standards are primarily for use in primary care, and as we are not directly seeing the patient as the first contact, not all of it can be directly implemented. For example, no control over the use of X-rays to diagnose prior to the referral. The other limitation is that referrals are often received or can be received further down the pathway when they've been referred to orthopaedics. Finally, here are some links to some useful websites. We have the link to the quality standards and the NICE guidelines, as well as information on the NHS Choice website and Arthritis UK website. If you would like any further information, then do not hesitate to contact me. Thank you.